Good morning. Today I'll be talking about intraoral films. The contents of my lecture include an introduction, classification of X-ray films, composition of an IOPR film, parts of an IOPR film, and finally the conclusion. So to begin with, the X-ray photons or the X-ray beam that exits from an X-ray tube is basically called as a primary X-ray beam. This X-ray beam, once it interacts with the dental arch of the human body, it undergoes attenuation, basically by process of absorption and scattering, which is basically nothing but your interactions of X-ray with matter. Attenuation is nothing but reduction in intensity. And the remnant X-ray beam, which exits from the dental arches of the human body, carries all the necessary information, which is useful as your diagnostic radiographic image. However, to record this invisible remnant X-ray beam, which carries all the diagnostic information, we need a recording medium this is where our X-ray film basically comes into play. So the main recording medium or the image receptor in dental radiography is nothing but our X-ray film. Now moving on to the classification, we have got 6 major classifications, and the first classification is based according to its use. So you have got intraoral films and you have got extraoral films. Intraoral films are films that are placed within the oral cavity, and extraoral films are films that are placed outside the oral cavity. Intraoral films can further be classified into periapical films, occlusal films, and bite-wing films. Now, these periapical films can be further classified depending upon their sizes, as size number 0 for children, size number 1 for standard anterior adult projections, not standard, and size number 2 for standard adult projections. Now, the second classification is based according to the coating of the emulsion. Emulsion is a principal component of our X-ray film, which I'll deal in your coming slides. So according to the coating of the emulsion, you've got single coated films and you've got double coated films. Single coated films are films in which you have got only a single layer of emulsion over the base, and in double coated films, you have got 2 layers of emulsion on either side of the base. Single coated films are usually used in industrial radiography as it requires much higher amount of X-radiation exposure to create a very sharp image. However, in dental radiography, we use these double coated emulsion films because it requires comparatively lesser amount of exposure for creating a very clear radiographic image. The third classification is according to the speed of the film. The speed of the film is determined basically by the size of the silver halide grains in your emulsion. All this will be dealt in the coming slides. So according to the speed of the films, you've got slow films, you've got fast films, and you've got hyper speed G films. These slow films, their silver halide grain crystal size will be much more very smaller, and they're usually denoted by the letters A, B, and C. And if you see according to the layer of the emulsion, these slow films are usually having only single-sided emulsions. And in your fast films, which we usually use in dentistry, they're usually denoted by the letters D, E, and F. If you see, the size of the silver halide crystal grains are much more larger, and they are usually double-sided emulsion films. Hyperspeed G films require only half the amount of X-ray exposure as that of your fast films to create a very clear radiographic image. The fourth classification is according to the packaging. That is, in a film packet, how many X-ray films would you find? So you have got single film packets and you have got double film packets. So in single film packets, as the name denotes, if you open the packet, you will just get a single X-ray film. But in double film packets, and that is single film packets are what is commonly used in our clinics and our OPs, and double film packets, once you open them, you will be able to see 2 X-ray films placed very close to each other. So the function of the second X-ray film is basically it serves as a duplicate, especially in your medico-legal cases where one is given to the patient and the other one is preserved for future use. The fifth classification is according to the use of screens. These screens are nothing but your intensifying screens. So the intensifying screens, what is an intensifying screen, its function, and what are screen films, all will be dealt in your future classes. For now, just understand that you have got 2 types of films according to the use of screens. That is, films which are used with screen, they are called as screen films, and you have got films which are not used without screens, which is basically your non-screen films. And these screen films can be further classified according to the range of the wavelength of the light that it is more sensitive to. You have got screen films which are sensitive to blue light, and you have got screen films which are sensitive to green light. And the last classification is according to the use of barrier envelopes or the availability of barrier envelopes. So you've got films with barrier envelopes and you have got films without barrier envelopes. So these films with barrier envelopes will ensure that there is no gross contamination of the patient's saliva into the dark room. So these films with barrier envelopes, as you can see in the picture, along with this barrier, it is placed within the patient's mouth, and once it is exposed, you tear open the outer barrier and you drop in only the X-ray film into a disposable paper cup. So into the dark room, you carry only the clean X-ray film and the disposable paper cup, and you are breaking the chain of infection from this of the patient's saliva within the X-ray room itself, not carrying it over to the dark room. However, in our daily OP and clinical practice, we usually use X-ray films without any barrier envelopes. Now moving on to the parts of an X-ray film. So an X-ray film packet is nothing but composed of 4 layers. That is the outer moisture-proof and light-proof plastic film packet. Then you've got a layer of a lead foil, and then you have a layer of a black light-proof interleaf paper wrapper, and finally your X-ray film. Now, each layer has its own functions, which I'll be dealing right now. And this is basically nothing but a pictorial representation once you open the film packet. The outer plastic wrapping film packet is nothing but made out of soft vinyl and semi-stiff. That is, once you adapt the X-ray film into the patient's mouth, it should never be distorted. Like when you adapt it to the arch, it should never get bent or easily distorted. So it should be semi-stiff. And this X-ray film packet is basically hermetically sealed from any sort of light or moisture contamination. Light is your visible light, and moisture contamination is basically the saliva seeping it into the X-ray film. Now this outer plastic wrapper packet actually has got 2 sides. One is your tube side and your other is called as your label side. The tube side, as the name indicates, is a side which is directed towards your X-ray tube. Now, it is usually solid white in color, and you will be able to see a small raised dot on one side of this tube, of this film, of this outer plastic wrapper. This dot is also called as your orientation dot or your occlusal dot. So why such a name is because this dot actually helps you in orienting the position of the X-ray film in the patient's mouth. So once you insert the film into the patient's mouth, you should always make sure this occlusal dot or this orientation dot is supposed to be placed towards your incisive or your occlusal margin. That is the edge of the film of the outer plastic cover that has this orientation dot should be placed towards the incisive or the occlusal margin, and the dot, the raised surface, should be facing towards the X-ray tube. Now, if you can notice in this pictorial representation, this double line is your outer plastic wrapper. Then you've got a paper wrapper, you've got a lead foil, and you can see the X-ray film itself. And if you can see, this dot is basically permeating through all its layer. So on the tube side, if you can see, the dot is basically projected, and on the label side is basically kind of depressed, right? So the raised surface is the surface that should be projected towards your tube side. So that's why it's also called as your orientation dot or your occlusal dot. Now moving on to the label side. Label side is the opposite side of that of your tube side. So label side, basically it has got 2 colors. Okay, so the flap is basically white in color, and the remaining of the film outer plastic wrapper is just blue in color. And this flap is what is used to lift and to basically lift and expose the inner components of your X-ray film packet. All right, and this label side is supposed to be facing towards your tongue, and I told you the depressed surface of your orientation dot or your occlusal dot should also be facing away from the tube towards your tongue. That is why I keep repeating, you have got a label side and you have got a tube side. The tube side, the dot, the raised surface is supposed to be facing the tube. That's why it's also called as your tube side. The other side is called as your label side. The total opposite of it is called as your label side. That is supposed to be facing your tongue, and that area, the orientation dot, is basically depressed. Moving on to the second layer is your lead foil. There's a thin layer of your thin sheet of your lead foil, which is basically placed towards your label side, which is back. Okay, so which is away from the tube side towards your tongue. This lead foil basically provides an ample amount of rigidity. Like I said, your X-ray film should not get distorted when you try adapting it into the patient's mouth. And not only that, if you notice, this lead foil has got basically an embossed pattern over it. That is basically a print pattern like you can see in this image over this lead foil. Now, this embossed pattern has a very good use in orientation also, which I'll tell you in the next slide. So this lead foil, other than providing rigidity, it also serves other purposes like shielding the film from any sort of backscatter or secondary radiation that exits from the patient. Why? Because this secondary radiation can create fogging of the X-ray image, and it can reduce the subject contrast, thus reducing the quality of your radiographic image. Also, it up to a certain extent, it can actually absorb some amount of residual X-ray beam that exits from the patient. So it provides some sort of amount of patient protection from unwanted residual X-ray beam also. This picture is nothing but the four parts of your X-ray film packet. This is your outer film plastic wrapper packet. This is your lead foil. This is your paper wrapper, and this is your X-ray film. Now, I told you about this embossed pattern. This embossed pattern is supposed to be, this embossed pattern on the lead foil, everything is supposed to be placed towards your tongue. Now, what will happen if you place a film rightly opposite? That is, your lead foil is facing towards your tube. That is, your label side is facing the X-ray tube. What will happen is you will get a characteristic radiographic fault, which is called as your herringbone pattern or your tire track pattern, that like you can see in this image. That is, you will be able to see the pattern of that embossed pattern onto the radiograph. Okay, onto the dental radiograph, you will be able to see the embossed pattern of your lead foil embedded. Now, not only that, because like I told you in the previous slide, lead foil absorbs some amount of radiation. So the primary X-ray beam, once it exits from the patient's mouth, the first layer that it's going to be falling on is to your plastic wrapper. The second layer is immediately your lead foil. So your lead foil will absorb most of the radiation, as a result of which you will get a very, very light radiographic image. So this, if you ever in your clinical practice come across a radiographic image which is very light and which has got a sort of a tire track appearance on it, always keep it in mind that the person who has taken the radiograph has placed the film in the opposite direction. That is, the tube side towards the tongue and the label side towards the X-ray tube. The third part is your black paper wrapper, which actually basically protects the X-ray film and from any sort of light leak. And last is our major component, which is your X-ray film. This X-ray film has got rounded corners, and like I told you earlier, you have got an orientation dot or an occlusal dot which permeates through all the layers of the X-ray film. And this dot actually in an X-ray film will actually help you in identifying whether it's the patient's right side or the left side, because always patients will come with X-ray films, or somebody will always come with an X-ray film for your diagnostic inputs. That time you will not be able to know as to how that film has been placed into the patient's mouth. So it is with the use of this orientation dot that you actually determine whether it's maxilla and mandible and whether it's the patient's right or the left quadrant. Now, depending upon the area that the film, intraoral film images, it has got three classifications of periapical films, occlusal films, and your bite-wing films. So periapical films are basically indicated when you need to record the crowns, the root, as well as the periapical region of the tooth. Occlusal films are indicated when you need to see the entire maxilla or the mandible in a single radiograph. And bite-wing films are indicated where you have to record the crowns of both maxilla and mandible in a single radiograph. However, keep it in mind, other than the crowns and the interproximal areas, you will never be able to see the periapical or the root apices. This is just an example of an intraoral periapical radiograph. This is a bite-wing radiograph where you are able to see the maxilla and the mandibular crowns and the interproximal areas, but you're not able to see the root apices or the periapical regions. And this is an image of a maxillary occlusal radiograph where you are able to see the entire maxilla in a single radiograph. Now, like I mentioned earlier, films are also classified according to their film sizes. So you've got size 0 for children, size 1 for anterior, and size 2 for standard adult projection. Size 2, 31 into 41 millimeter is what we usually use in our clinical practice. And occlusal films of size 2, 57 into 76 millimeter is what we usually use in our clinical practice. Now, moving on to the composition of the X-ray film. So parts of your X-ray film are basically what you see grossly, but composition of an X-ray film is what you see through a microscope. Okay, so this is a scanning electron micrograph of an X-ray film, which is seen higher magnification. So you've got 4 layers in an X-ray film, not parts, just that X-ray film, that single layer of X-ray film, you usually have 4 layers. You've got a base, you've got a substratum, you've got an emulsion, and you've got a supercoat. Each layer and its functions, I'll be telling it in the coming slides. So the base and the emulsion is basically called as the 2 main principal components of your X-ray film. So the base is one of the major components because it provides support for the further layers. It is composed of polyethylene terephthalate, and it is 0.18 millimeter thick. It is usually flexible to an extent so that it is easily adapted to the patient's mouth, and it is usually uniformly translucent. It should not have any sort of coloring, as it will hamper in our diagnostic image process. And this base should be made out of a material such that it is able to withstand any exposure to processing solutions, because invariably your X-rays, once it's exposed, is going to be dipped into various chemicals such as your developer and your fixing solutions to create a visible radiographic image. So once you dip your X-ray films into your processing solutions, it should not get distorted by any means. Also, once you dry it, once the film is being dried before disposal to the patient or to the dentist, you are supposed to be drying it under heat. So it should not get distorted under any sort of heat also, or any sort of chemical exposure. These are the functions of your base. Now moving on to the substratum or your subcoating. Now the base as you can see in this picture, is a major component of your X-ray film. The next layer on either side of the base is basically a substratum or subcoating. It is nothing but a thin layer of adhesive material to ensure that your emulsion and your base stick very well with each other. I told you just some time ago that your base and emulsion are the major principal components of your IOPR film. So to ensure that your emulsion and your film are properly in contact with each other with good adhesion, there is a small layer of substratum between your sensitive emulsion and your film base. Now, third is your emulsion, which is the major component of your X-ray film, in which a lot of chemical changes occur to create a radiographic image. And from these changes in your emulsion is from where you are able to get various diagnostic information. Now, your emulsion is basically composed of your vehicle matrix and your silver halide grains. These silver halide grains, 99% is of silver bromide, and almost only 1 to 10% is only of silver iodide. The reason why silver iodide is added on to your silver bromide crystals is basically because it creates surface irregularities, which will actually increase the radio sensitivity of your film. Now, apart from silver iodide crystals, the manufacturers also add small amounts of sulfur compounds also to increase the photosensitivity of your X-ray film. Now, these silver halide crystals are sensitive not just to X-ray radiation, but also to visible light. That is the reason why in your X-ray film packet, you have got multiple layers. That is, you have got your plastic outer wrapper, you have got your black paper wrapper protecting your X-ray film. That is basically a silver halide crystals in your emulsion from any sort of exposure to visible light. Now, your vehicle matrix. Your vehicle matrix basically provides a medium in which your silver halide crystals are always uniformly dispersed. It is usually made out of either gelatinous or non-gelatinous material. And the other function, other than keeping these silver halide crystals completely uniformly dispersed, it also swells up once the film is being dipped into your developer and fixer solutions. This vehicle matrix is what swells up, allowing your developer and your fixing solution chemicals to easily penetrate and reach your silver halide grains, so that further chemical changes are being undertaken to create a permanent radiographic image. Okay, so that's what I've told right now. It allows the chemicals of your developer and your fixer solution to react with your silver halide grains to create a radiographic image. Now moving on to your super coat, that is your outermost layer. It is nothing but a transparent abrasive layer so that the underlying layers of your emulsion and your base are not distorted in case of any sort of scratching or contamination or any pressure from your automatic processor rollers. So like you can see over here, your scanning electromicrograph, your base is of 1.18 millimeter thickness. The substratum has not been marked here, but it is supposed to be a very thin layer that is just there on either side of the base. After that only comes your emulsion, which is the main area where all your changes occur, and from the layer where your radiographic image actually occurs. And then you have got your outer coat or your overcoat or your super coat, which is supposed to be completely transparent, and it is supposed to be completely protecting the underlying thin layers from any sort of mechanical abrasions. Now, if you see our intraoral films, all our intraoral dental films, they're actually called as direct exposure films because they do not need any other sort of medium to create a radiographic image. You just need to place these radiographs into the patient's mouth and expose them to X-rays and you get a radiographic image. But you have another set of films called as non-direct exposure films. Okay, these are all your intensifying screen film combinations and all, where you need an intensifying screen so that if the film is placed within the intensifying screen, once the X-ray films fall onto the intensifying screens, it will emit visible light, and then that visible light is what creates a radiographic image. So finally, to conclude, this chapter is very important because this provides a complete, thorough, basic knowledge of the various components of an X-ray film, the function of each component of the X-ray film, as well as its composition. So with this knowledge, you will actually know how to orient the film into the patient's mouth, as well as to identify any radiographic faults if done by anybody else, and to actually overlook those faults and actually give off a proper diagnostic information from that particular radiograph. And also by the knowledge about the various composition of the various layers of how thin and delicate they are, you will actually learn as to how to gently handle these films and to prevent any sort of rough handling, to prevent any sort of damage into your radiographic images. So I hope I'm very clear, and this actually provides your basic knowledge about the parts and composition of your X-ray film. Thank you for your patient listening.